Hello, friends. So, I'll be giving a nice overview on this very nice topic. How do we manage a patient with a severe TBI with a chest trauma? So, with a possible ARDS, obviously, a polytrauma with a severe trauma to the chest, you would want to discuss about how you would manage the challenges of ARDS with a traumatic brain injury. So I'll just take you through a sort of an evidence-based approach to this particular topic. And I was asked to give a talk on this in Trivandrum in South Zone Conference on 23rd August. So the topics I would cover is a bit of a background where these two life-threatening conditions coexist, where there's a traumatic brain injury and severe ARDS or chest injury. And what do we do in ARDS? So we adopt low tidal volume, but is low tidal volume safe for the brain? Because that's the question in mind. And whether high tidal volume is something obviously we don't subscribe to. And high PEEP is something we give to ARDS, whether this can be adopted in severe traumatic brain injury. Obviously, there are ramifications for that. And whether can we do recruitment maneuvers, whether we can use pulmonary vasodilators, and how about steroids? Because we tend to use steroids in ARDS. Does it have deleterious effects in traumatic brain injury? How about proning when there is a traumatic brain injury with ARDS? And how about the role for ECMO? More so in ECMO where you have to use anticoagulation and that would have a very deleterious effects on the traumatic brain. So these are some of the diabolical sort of a situation that tends to coexist when there is a severe traumatic brain injury with ARDS. So I'll take you through a very nice illustrative example, which we managed in our ICU just a month back. So I'll just take you to this case scenario. This is a real patient. I'll show you the pictures as well. 25-year-old gentleman who met with a road traffic accident, and he sort of it happened in a place called Tumkur, nearby Tumkur, and he spent around 16 hours of criminal waste of time in a medical college hospital nearby. And when he came to us, he had a GCS of E1, M2, V1, obviously with severe traumatic brain injury with contusions and subarachnoid hemorrhage, multiple rib fractures. And basically, what he had is he fell from the bike, and then there was a tractor which ran over his chest. So it was that bad injury. So bilateral hemothorax and left pneumothorax, hemoperitoneum, and all sorts of injuries that you can expect. Grade 3 liver injury with bleeding with hemoperitoneum, grade 2 splenic injury, grade 1 renal injury, right adrenal hematoma, hemoperitoneum, humerus fracture, and scapula. So this was a very sort of a vicious sort of a trauma that he's had, or a catastrophic or disastrous trauma. So obviously he was intubated, mechanically ventilated, underwater saline drains put in. So this was the chest. As you see, he has bilateral contusions and with with the PF ratios less than 100. And he had a florid sort of an ARDS. And he basically, when he came to ICU, his PCO2 was sitting around 130. So obviously, we did all sorts of maneuvers for maybe few hours. GCS was 3. So we weren't sure. Anyway, we took a hard call that we should initiate him on ECMO. So this is a huge challenge, friends. So initiating ECMO in patients with severe trauma, polytrauma, with a traumatic brain injury, with hemoperitoneum, there are huge challenges. So this is not the topic. So we'll just talk how ECMO can be an option. And this was his CO2. So 118, we initiated ECMO. We ran without anticoagulations for 48 hours. His CO2, we got it down gradually, 53.9. And 12 days he was on VV ECMO. So no heparin for 48 hours. He developed AKI, and he was put on renal replacement therapy. And as you see, there was a lot of bleeding at the underwater saline drain site, which we managed. There was a bleeding at the tracheostomy, so on and so forth. So anyway, that's the sort of a uh, context setting for you guys as to how this sort of a complex patient could be saved with a good sort of a ICU management. He's a young guy, so he has a bright future. So we had to put in all measures to save his life. Anyway, so weaning was complicated with left lung collapse, all this, basically the bleeding complications. So he had to undergo bronchs to clear some of these sort of blood clots. And anyway, it was a success story. I'll show you the pictures at the end. So that was the context setting as to why we are discussing this topic. So when there is background, we look into when there's severe acute brain injury. So what happens? So obviously there is an injury, there is increased in the pressures in the intravascular pressure. So what we need to understand is when there is traumatic brain injury, there is a brain-lung axis that gets activated. So just because there is a severe traumatic brain injury, it doesn't mean that your lungs get affected. The vascular integrity at the alveolar capillary junction also get affected. And this leads to, and when there is a brain injury, any inflammation anywhere, there is a cytokine sort of a storm that happens. A lot of inflammatory cytokines get released, and there is activation of all these microglial cells, astrocytes, so on and so forth, and there is alteration in the blood-brain barrier. So this is the sort of a vicious conundrum that happens in traumatic. So basically, cytokine storm, interleukins get released. When there is this release happening, there is a disruption of alveolar capillary membrane also, and that can lead to lung injury also. And when there is a hypothalamic injury, in a severe traumatic injury, especially in trauma where corpus callosum and hypothalamus get affected, there can be autonomic dysfunction. And this autonomic dysfunction leads to inactivation of the surfactant production, which leads to increase in the pulmonary vascular resistance and capillary hypertension. If posterior hypothalamus is involved, so basically this background what I'm giving is how there is a brain and lung axis functioning. When there is a brain injury, there are changes that happen in the lung. So when there is posterior hypothalamus, increase in the alpha adrenergic drive happens, and it is shown that 40% of severe traumatic brain injury by the virtue of brain injury itself can lead to ARDS, not the trauma to the chest. The fact that they have brain injury itself can cause ARDS. And the treatment of ARDS, which is permissive hypercapnia, high PEEP, all these can lead to increase in the intracranial pressure and reduction in the cerebral perfusion pressure, which are deleterious to the brain. And this gentleman, 25-year-old gentleman, came with GCS of M2E1 V1. So now we'll go into how do we manage such ARDS. So obviously the traditional teaching is we need to give low tidal volume ventilation, have plateau pressures less than 30, driving pressure less than 50. These are all the traditional archaic teaching, but in traumatic, can we do that? So obviously when you do low tidal volume, what happens? CO2 increases. And because you're giving low tidal volume, your oxygenation comes down. So what happens when CO2 increases? When CO2 increases, your ICP goes up. And because there is a systemic hypoxemia, there is a brain tissue hypoxemia that happens. And physiologically, this is very important, friends. Why use tidal volume? The studies have shown with every 1 ml increase in the tidal volume of more than 6 ml per kg, which we adopt in ARDS, the odds of worsening ARDS is 1.3, which means you give higher tidal volume. It's a trade-off that you can worsen the ARDS in traumatic brain injury. And the ARMA trials have clearly shown low tidal volume leads to 9% absolute risk reduction in the mortality. And there is increase in the ventilatory free days, which is good. And the targets that we have largely accepted is try to maintain permissive hypoxemia or permissive hypercapnia, where we are happy in ARDS saturation of 55 to 80 and pH more than 7.15. But is this acceptable in traumatic brain injury is the question. So what happens in traumatic brain injury when you follow ARDS protocol and accept permissive hypercapnia and hypoxemia? We know your ICPs go up, CPPs come down. So when there is a high carbon dioxide, it causes vasodilatation. So the cerebral vasodilatation happens, there's increase in the ICP, and so there is cerebral hypoxemia that happens. But if you try to correct this hypercapnia by hyperventilation, that is also deleterious, because hyperventilation is shown to cause vasoconstriction. Obviously, it reduces ICP, which is good, but this vasoconstriction can lead to ischemic deficits, which is bad. So you see how the trade-off happens. So if you accept high CO2, vasodilatation happens, high ICP. So if you try to hyperventilate and cause vasoconstriction, it can lead to ischemic deficits. So these are the trade-offs that happen. So PaCO2 of less than 25 millimeter mercury for more than 30 minutes is not acceptable in traumatic brain injury. Targets are basically targets in any brain injury should be normoxemia and normocapnia. So you maintain at 35 to 45, which is normocapnia. This is very important. So the take-home message is in traumatic brain injury, severe acute brain injury, these are the 3 studies, one from Australia, one from Norway, one from USA, where they've shown if you maintain PaO2, which we accept at a lower level of 55 to whatever 60 or 70, but PaO2 less than 110 millimeter mercury in traumatic brain injury, it's shown 50% higher odds of death happen. So can we accept this in ARDS? Because because there's a trade-off. You maintain lower oxygenation, 50% odds of death is there due to severe TBI. So we have to accept higher PaO2. So the summary is You can maintain low tidal volume ventilation, but you have to strike a balance that you don't create hypoxemia and you don't create hypercapnia. It's a very hard call. So you have to calibrate and individualize targets of ICP and brain tissue oxygen. So look at this. This is what you have to do if there is a traumatic brain injury and you want to maintain adequate oxygen with low tidal volume. So the ideal target is CO2 is normocapnia, but PaO2 should be more than 110 millimeter mercury to minimize the death risk due to severe traumatic brain injury, because there's 50% odds of increasing death if you maintain less than 110. So this is what we can deduce, that it's a trade-off. You can't maintain low oxygenation. Now coming to high PEEP. So because we use PEEP in ARDS, high PEEP, we know it improves oxygenation, but high PEEP increases ICP. When there is increase in ICP, there is reduction in the cerebral perfusion pressure. The physiology is we use high PEEP because we want to increase the functional residual capacity, improve the ventilation perfusion, and recruit the de-recruited alveoli and prevent the alveolar collapse. So we do the PEEP optimization by titration table, transpulmonary pressure, optimizing driving pressure, and pressure volume loops. So when PEEP, you increase PEEP in traumatic brain injury, your intrathoracic pressure goes up. When intrathoracic pressure goes up, your venous return is impeded. When there is a venous return in the brain that is impeded, there's increase in the ICP and there is cerebral hypoxemia. So this is also a very nice sort of a physiological mechanism. If the auto-regulation is intact, there is some sort of a cerebral vasodilatation that tends to happen. But if there is auto-regulation is impaired, we saw this. When CO2 goes up, you have vasodilatation. When CO2 comes down, you have vasoconstriction leading to. Same thing happens with P. So when the auto-regulation is intact, vasodilatation happens. But if auto-regulation is impaired, high PEEP can cause vasoconstriction leading to ischemic deficits. So high PEEP in more than 50% of patients with traumatic brain injury have impaired auto. So you have to sort of assume that in patients with severe traumatic brain injury, there is some sort of impaired sort of an auto-regulation. So when you give high PEEP, there's a risk of vasoconstriction and ischemic deficits. But what I've found, there are studies, this from Italy and US, which have shown you can tolerate PEEP up to 14, because up to 14, these deleterious changes of vasodilatation or vasoconstriction does not happen, and it is considered safe to go to the PEEP up to 14, or definitely up to 12, it is safe. And studies have shown up to 12 centimeter of water, there's no significant change in ICP. So which means low tidal volume is acceptable provided CO2 is maintained normal, provided you are able to maintain the oxygen more than 110. And PEEP, you can go up to 14, more than 12, definitely you can go up to 12. It does not cause any increase in the ICP. So this is a good sort of a message for you guys. Recruitment. So I think we have de-emphasized on recruitment maneuver even in ARDS. So the intent of recruitment is it opens the alveoli, but what does recruitment do? Increase the very PEEP to up to 35 to 40. It can cause hypotension. And we know hypotension is terribly, terribly bad in patients with ARDS because the hazardous, it causes hazardous sort of systemic and cerebral hemodynamic change. And hypotension is bad because it reduces cerebral perfusion pressure. So this randomized controlled trial that was published showed aggressive recruitment maneuver with high PEEP, in fact, has shown increased mortality, hemodynamic collapse, and barotrauma. So the evidence suggests PEEP of 25 to 35, which is used as a recruitment, will increase ICP, reduces the CPP. So the recommendation or suggestion is recruitment maneuvers to be avoided. I think which we have largely accepted even in patients with severe ARDS. We don't do recruitment maneuvers anymore these days. So this is something. So the lessons learned is low tidal volume is okay, but PO2 more than 110. PEEP, high PEEP up to 12 to 14 is okay, even in traumatic, severe traumatic brain injury, but don't do recruitment maneuvers. So what about pulmonary vasodilators? So pulmonary vasodilators also has been used, which tends to improve ventilator perfusion mass match and prevents hypoxemia, but your pulmonary vasodilators can inhibit platelet functions, and due to synergism with P2Y12 inhibitors, there are certain case reports which have shown your vasodilators tend to improve ICP by improving the oxygenation and improves the cerebral oxygen delivery. But you are using vasodilators, the trade-off is because it vasodilates, it causes hypotension and there can be increase in the risk of bleeding. So the summary is there is limited data on the safety and efficacy of using pulmonary vasodilators in patients with dual injury of traumatic brain injury and ARDS. So we saw vasodilators have a limited role. So what about fluid management? So largely we have accepted anything to do with traumatic, we want euvolemia. But in ARDS, we try to keep the lungs dry. So there's a trade-off. Challenges is conservative fluids is what we use because it is shown to reduce the duration of mechanical ventilation. But when you create conservative and cause hypovolemia, this is bad because we want euvolemia. Hypovolemia reduces the CPP. But if you give aggressive hypertonic sort of a saline treatment, it can cause some sort of a hypervolemia also, which is also not very good. So why we use hypertonic saline? Because basically you increase the tonicity in the intravascular compartment. This increase in the tonicity pulls the edema that is present in the cells and pulls the edema which is present in the interstitium of the brain and reduces brain edema. That's why we use hypertonic saline with an intent that we reduce ICP. So the evidence has shown the FACT trial, conservative fluid management was found to be good. It increases ventilatory, this is in ARDS, increases ventilatory free days, improves gas exchange. But the theoretical risk in severe acute brain injury is euvolemia has to be maintained. Hypovolemia is bad because it can reduce CPP. Hypervolemia is bad because it can worsen edema. Hypertonic saline is something you can use. So euvolemia is the way to go. Hypertonic saline, if they have underlying comorbidities like heart failure, one should avoid. Mannitol, obviously, if you use overzealously, it can cause acute kidney injury. The summary is fluid resuscitation is a prescription, is a therapeutic, which are very clear endpoints of maintaining euvolemia and hemodynamic stabilization. And you should just give enough fluid to maintain euvolemia to maintain cerebral perfusion pressure and cerebral oxygenations. And please avoid hypotension by restricting fluid in traumatic brain injury. And one has to bear in mind to maintain CPP in subarachnoid hemorrhage because our patient had severe traumatic brain injury with subarachnoid hemorrhage and bitemporal sort of a contusions. So that's very clear. So we spoke about low tidal volume is acceptable provided your PO2 is more than 110. High PEEP up to 12 to 14 is okay. And pulmonary vasodilators have a problem because it can cause hypotension and there is limited data. And you have volume issues where you have to maintain euvolemia. Hypovolemia is bad for the brain. So how about steroids? So because we use steroids in ARDS, we use steroids. There's a lot of studies, the recovery trial in COVID and the DEXA trial showed that it reduces lung inflammation, improves the outcome. But in traumatic brain injury, you use steroids, it causes water retention, increases the brain edema. Studies have shown it can increase the hemorrhage, increase the ischemic deficits, and it can increase the seizure threshold. So it worse outcome. So corticosteroids has been also shown to be independent risk factors for ICU-acquired weakness. So corticosteroids are beneficial in ARDS. So one has to weigh. If ARDS is severe, you may have to use steroids. But if traumatic brain injury is severe, you may have to be cautious. In our patient, we did use steroids. So you have to balance the risk-benefit sort of a balance when you're considering steroids. So what about prone positioning? This is very interesting, friends. I think the challenges of prone is that our understanding is it increases the ICP. How it increases ICP? By inhibiting the venous returns in the neck in the prone position. But PROSERVA trial in ARDS showed good mortality benefit when someone is prone for more than 16 hours. So evidence is not clear that in traumatic can be prone. So the suggestion is you can prone with the head elevation, reverse Trendelenburg of this nature you can use in patients with traumatic brain injury. And it is shown in this reverse Trendelenburg position with the head and elevation, changes in ICP and CPP were not significant. That was shown in this particular study from USA. And there is a very interesting concept of supine chest compression. So basically, keeping the weight, 100 grams per kg is the therapy of the prescription, where you keep the patient weighs 60 kgs. So you basically 60 into 100. So 6 kgs is what you can keep on the chest to cause chest compression. And this has shown to have changes in the elastic chest wall compliance and improves the tidal volume and creates some sort of a PEEP by supine chest compression by moving the diaphragm. So 30-degree elevation with the weight that is kept on the chest is considered similar to prone positioning. And this is suggested for 8 to 12 hours. There is a trial ongoing. I checked whether there is this results of the trial is out, which is not out. Alter prone trial, where they're using 100 grams per kg for 3 hours of this weight. And it is shown, and in this particular trial, they have included patients with a high ICP of more than 30 millimeter or cerebral perfusion pressure less than 60 were included in part of this trial. So it will be very exciting, friends, to follow through this trial and see the results if at all this gets completed, whether this supine sort of a chest compression with the weight with 100 grams per kg was effective. So this is how we keep. So I think this is one of our patients where we kept this, where we couldn't supine, we kept this sort of a weight on the chest to create this artificial sort of a proning effect by increasing the tidal volume and PEEP, friends. So this is something interesting. So that's a take home for you. If you cannot prone, at least keep some weight. 100 grams per kg for 3 hours is what you can keep, which gives a similar effect of proning. So how about ECMO? So ECMO Caesar trial showed in specialist ECMO center, higher survival rate, reduced 6 months disability. Earlier trial, which came in 2000, which we have discussed and debated. Secondary endpoints is it reduced treatment failure, reduced the risk of RRT, and reduced the risk of prone positioning. So ECMO, the arguments are it can increase ICP because you use anticoagulants, it can cause bleed and it can cause ischemic defeats. It impedes the venous return. You cannot use heparin, and there are concept of pumpless extracorporeal left LA acid devices, and case reports have suggested that modified anticoagulation could be considered. And in our patient, we did not use anticoagulation for 48 hours, and we calibrated the sort of an ECMO anticoagulation management post 48 hours to minimize the risk of bleeding. So there are case reports to suggest modified anticoagulants can be used with severe traumatic brain injury with ARDS. ECMO can be used, and we used in our patients. So friends, severe traumatic brain injury or polytrauma is not an exclusion for doing ECMO, because the first ECMO done worldwide was in a polytrauma patient. So please bear, and traumatic brain injury is not a excluding criteria for doing ECMO, and we can save young lives by putting them on ECMO when all other measures fail. And even they have done ECMO in patients who have undergone decompressive craniectomy. So there are good sort of a scientific reports, although you cannot have a big randomized control trial on this. So friends, the happy ending for our patient is, you can see me there. So this is our ECMO patient. We celebrated his success and decannulation and his birthday also that came by cutting the cake. And this is the patient who came for follow-up after complete decannulation. Is perfectly normal, completely improved with GCS, and he came walking to our ICU place. So this is the happy ending, how you can manage. So there is always different measures, different maneuvers that you can put in place, especially if you have a severe traumatic brain injury with a chest trauma. So don't miss out on these options to save valuable lives. And I end with this quote: I never lose, either I win or I learn. So I would have learned from this case. We learned from this case. So go for it and save more lives, friends. So thank you. Thank you, one and all.